sir, Manav Jyoti sir, and Manoj Khatri sir. I would like to speak our first speaker, Dr. Manoj.
So good morning. The last day we are all used to having less attendance. So I don't know if the first speaker is here, endogenous endophthalmitis. So we'll begin with Vishal on pediatric RDs. Pediatric RD is one of the tough situations to manage. I think primarily because the vitreous is sticky. That's the most important thing there. And there's always a dilemma. But let's hear Vishal. He has innovative ways of separating the vitreous from the retina. Because if that comes out, the success is there. See, the entire thought process revolves around that.
Good morning, everybody, and thank you, Elizabeth. I'll be speaking on the pulse of vitrectomy pediatric retinal detachments. As we all know, retinal detachments in the pediatric population will account for a significant number of total detachments we see. The most common causes are trauma, myopia, aphasia, ROPD, and other less common etiologies. Approximately 70% of the patients are male. They are mostly related to trauma, congenital anomalies, unlike adult cases. We all know that scleral buckling is a gold standard in terms of the first line of surgical management. But due to the varied anatomy, late presentation, and altered VR additions, being many such cases unsuitable for scleral buckling when they present to us. So, surgery is of course a small part of what we do. Basically, a thorough evaluation, that is systemic workup, EUA, and the other eye staining, sibling staining, and FFA in patients of FEVR, and prophylactic laser is very important. And of course, a thorough counseling like risk and benefit has to be explained to the parents. So, in the next few videos, I will be discussing and touching all these topics: class, lens management, PVD induction, staining, and base dissection, etc. So, coming to the PVD part, as particular is the most difficult part. So, there are two parts to it. First is if there is a subtotal RD, then there is no need of any special technique to separate the RD. This is a projector system, so the video might not be very clear. So you go towards the attachment, and if you have support of attachment, then it becomes quite easy. You can see the fluid wave coming, and you can separate the hyaloid easily. So this is one scenario. But if you have a bullish attachment and a total retinal detachment, this technique might end up getting the retina into your cutter, and it might be traumatic. So this is a technique we have been following for many years. You inject the hyaloid with transfer estronide, do a core vitrectomy, inject small amount of PFC bubble, and make a hole in the hyaloid, and inject more PFC inside the PFC well. So it cleaves the hyaloid till the equator. Of course, you can't go to the periphery in these cases. And then you use your cutter and shave as much as possible till the periphery. So this is a very atraumatic and reproducible technique to induce PVD. So this is a wide angle view of the same. And if the pool is not getting enlarged, you can use your other instrument, a blunt dissector or a light type human, to enlarge the hole. The idea is to get the PFC bubble into that well. And after that, things become easy, and you can proceed like a routine surgery in these cases. Coming to the role of ensanglage, many cases it is necessary to use ensanglage, but as these are our anterior pathologies, you should be very careful that it should not be very tight. Otherwise, the dialysis edge gets inverted, and all the infusion fluid gets into the subretinal space, like in this case. So, a moderate or mild focal height is enough. And as you can see in this case, the domes, the cannula is king, and it was a dialysis case, and all the fluid was going into the subretinal space. You actually had to shift the cannula position to get the fluid into the vitreous cavity. Otherwise, there was no space for working. difficult to identify the posterior hyaloid. And in these cases, more than transfer my personal choice is of course the trypan blue, because that is a beautiful stain, and which apparently after the tricot staining you cannot see the hyaloid, but after the trypan blue dye and injection of PFCL, you can find a cleavage stain, and the whole thing comes out in a sheet. Of course, it takes time and repeated attempts with the different concepts, but still better than the transfer in terms of staining the hyaloid. As you can see, I am repeatedly maneuvering the posterior hyaloid stuck to the retinal surface very adroitly. And you cannot do these maneuvers without a PFCL in place. Otherwise, the whole retina is so bullous, it's impossible to grasp that layer. Now you can see it's coming off. And once the edge is grasped, then things become easy, and you can extend the area of the section. The point here is that there is no point in extending it beyond the arcade or beyond the equator, because it's very dense and you will end up making more iatrogenic tears. So this is the end of the PVD induction, and then you continue as your routine maneuver, do a rectomy, do laser, do fluid exchange and photoid. Coloboma is a rather difficult scenario, basically of the dense hyaloid adduction, specifically at the junction of the retina and the choroid. And in this scenario also, the technique works beautifully. And the trick here is not to do a lot of vitrectomy before injecting the PFC and starting to peel the hyaloid, because you need something to grasp on. If you do a lot of vitrectomy, there is not much tissue to grasp on. So you do a limited core vitrectomy, inject PFC, and then dissect off the hyaloid and do all the But these incompletes require a long-term follow, because they are very prone to secondary glaucoma even after silicone removals and recurrences. This is a case of FEVR, bilateral FEVR. The other eye was lasered, and this was done around 8 years back. The things we learned here was that this temporovascular band in the FEVR is very adherent to the retina. And there is no point in peeling it. You just have to shape the anterior and the posterior edge. If you try very vigorously to peel that, you will end up making iatrogenic tears. So you do a good base dissection, and you just try to shave off that temporovascular band and laser it properly. The patient does fine. So this was the other eye which we had lasered 8 years back, and we did paracritinal RD a couple of years back. And as you can see, there are so many multiple additions of the hyaloid to the retina. The whole periphery was well lasered, still the patient developed a regmatilus and a combined retinal detachment. And you can see a macular hole is also there, and it was covered by a thin membrane. So all the membranes were dissected, a thorough peripheral dissection was done, and the hole was closed with the inverted iron beam under PFCL. Sometimes the patient they have a very vascular retina, and you can inject pre-op anti-VEGF to minimize the intraoperative bleed here. Finally, more laser anterior to the fibrovascular band, posterior to the fibrovascular band. Of course, these are not single surgery cases. Some of them will eventually develop recurrences, and you have to go in very early, otherwise a lot of PVR sets in. And again, as I told you before, even if there is a membrane left or there is a recurrence, the trypan blue works beautifully, then the transform is correct. As you can see, the whole sheet from the macula to the periphery is coming out en masse. And this is a star fold which is being removed. And in these cases, you make sure that no more recurrences are there. So you do additional eyelid peeling also in these cases. Otherwise, the formation of macular pucker is very common. And these are not cosmetic cases. There are cases which have a lot of anterior PVR, and there is no point in thinking about retaining the lens here, because no amount of dissection will be complete in that anterior part without the sacrifice of a lens. So once you decide that even after membrane dissection there is a traction left, you do a generous retinotomy and fatten the retina. Small retinotomy won't work in these cases. You have to be generous enough to remove all the traction. Traumatic macular holes is another very common scenario in these cases. Dialysis or detachments with a macular hole. This is a very large macular hole, almost 1500 microns in size. And in this case, this inverted iron beam works very beautifully. You have to, catch hold of a larger area of iron. Just move it towards the. You don't need to stuff it inside the hole. Just have to move it inside the hole. Just clump it there, and then aspirate the pH, and it will not go anywhere. And as you can see, we have beautiful results in the tight conclusion in these cases. So to conclude, PPV in children is challenging because of the unique anatomy of the pediatric course, it's not a perfect science. Every case has to be managed individually. Final thing is the visual gain still is suboptimal in view of eight presentations and possible irreversible photoreceptor and disc damage. Thank you so much.
Thank you, Vishal, for another very good presentation. See, visual gain is not in your hand at all. Because in your hand is an magnifier attachment which itself is very challenging in pediatric. Anybody has any point? But I had a couple of observations which I will, because dialysis, whatever PVR somehow is very rare. Very rare. One odd case we should, but generally dialysis couple still remains the preferred choice. Other thing I wanted from was which temporary gain. We end up putting oil, but 1,000 or 5,000.
So 15
we can't depend on positioning.
Exactly. But they are generally 10 to 12 years old and they generally follow your instructions. They are not less than 5 years old. This one works well.
I agree with you that you should not be very aggressive in pulling off the thyroid, because most of them are phakic eyes, and if you keep pulling, you may have heterogeneous issues here. One good instrument is diamond duster to unroll this edge. Forceps, I'd be very wary of unrolling with forceps, because you use a diamond duster to scratch this.
Or the finesse loop.
That's a better.
But the issue with finesse loop is the longevity and the price is that diamond people can just last for ages. You can use for multiple cases and they give but almost equally as finesse loop.
So whatever you have, that's cost effectiveness. I agree. The tightening of the band, we are saying that if the band height is mildly moderate, that's the best point for you. But tightening should be done at the end of this thing, after you have cleared everything. If you do it before, then that issue of what you say is a retinal issue. After our retina is mobilized, then you should do mild. But wonderful presentation. As usual, any other point, but I agree. You see, sometimes we need to visualize the DVD or the thyroid return blue functions very, very nicely. Another thing is that in routine RDs, I am not very fond of peeling eyeliner, but in pediatric I am more fond, because apart from ensuring that there is no membranes left, post-op pucker is more common in such patients because of aggressiveness of the proliferative response. See, in routine RDs, you don't peel, but here if you peel post-op PVR, the macular pucker, you are seeing very severe pucker in pediatric RDs. So, any point that the Vilesh or anybody else?
If we ask, would you mind putting a buckle where you have that peripheral traction membrane, which you cannot
The
peel?
peripheral traction membrane is actually just temporal to the macula. So even if you put a very posterior buckle, it won't support that. That fibrovascular band I'm talking of, it just starts temporal to the macula and it ends before the periphery. It just does not extend beyond the equator. So there is no coordination of all it to support that.
All pediatric patients who are taking generally, and I definitely put a band.
Band.
No, broader buckle if it is a larger membrane on the temporal side, temporal periphery, to say vascular.
You can do that.
So rather than putting 2 millimeter, you can put a 4 millimeter. One question was, I don't know if anybody has tried, of a plasmin-induced vitreolysis.
That is what we were talking during breakfast. Plasmin actually, disturbs the retinal anatomy also. So that's why ocular plasmin is not in use nowadays, because it creates a incomplete PVD and it's more difficult actually. It's more difficult.
So not the ocular plasmin, but you can decant, you can use your own autologous blood and from that can be used. I think Dr. MBS has used it in some difficult cases. I don't know if anybody has tried.
For PVD?
I was for PVD.
They inject it pre-operatively.
No, intraoperative.
And wait for some time and it aids in the.
Actually,
Yeah, it's a good this thing, but ocular plasma in any case, apart
no,
from
that's too expensive.
yeah, apart from expense, reports of complications are higher. Functional, you see disturbances of ERG and lot of dark issue, yeah, I think it's
Sir, I've used it in 2 cases way back in 2013.
ocular plasma.
Ocular plasmin, not in India, but when I was doing my fellowship. It works only up to stage 2 holes, not more than that if there is a traction. And they usually try to inject it in the is extreme
That's what I
loss
was
of floaters.
when I
And
just
I have seen the patients coming back very cranky, very unhappy, and in those two cases, in one case, in fact, the whole size expanded. The whole size became more
that's
larger.
because plasmin or plasmin they effect has a pan India effect, pan retina effect. So they will disturb the collagen or laminin all across the retina. So
And the
therefore,
cost was
unexplained loss of
$4,000. The cost was $4,000, which was double the cost of the surgery.
So, in any case, irrespective of the cost, even if it question is even if it's cheaper, not even look at it. That's what I'm saying. Because of unexplained loss of vision, because of disturbance of ARG, because of night attack, dark adaptation issues, people universal. This is more than 75% complaints are there.
When I was a resident, they had given me a topic to speak on this. So I had done a little search of that. So there was a trial where they were to see if optical plasma can be used in pediatric retinal detachment for PVD injection. In majority of the time, they stopped the trial because whatever was happening was more of pictures. They thought that they had achieved a PVD because they were doing this thing, but by the time they reached the first follow-up by 1.5 months, majority of the patients had detailed pictures. So that's why the trial itself was stopped. The recruitment itself stopped after 6 months.
So thanks Vishal for that wonderful videos. I think we saw videos much clearer here than
Yeah.
So we'll move on and next will be Dr. Ajay, one of his favorite topics about the micropulse laser. Basically chronic CL.
Thank you, sir. So I'll be talking on my experiences subthreshold micropulse laser in CSR and retinal venous occlusions. No financial disclosures. I'll be talking to you on the basis of micropulse laser. Will not be covering much on acute CSR, but chronic CSR, non-ischemic CRV on branch retinal venous occlusion. So this was a very important study which happened in the early 70s, which showed that as the duration of a laser burn is reduced, the tissue damage is reduced. So there is potentially a point where you could actually work at just the RP or even at a subcellular level. So this is what a micropulse laser does. This is an electronic, shaving off of part of the continuous wave laser, so that you have a pulse coming up for a limited amount of time, and you have a relaxation time. With a continuous wave laser, there is a thermal damage, but with a micropulse laser, because of the cutting off, there is a relaxation time, and there is a possibility for the tissue to recover. So when you do a subthreshold continuous wave laser, you can still see a damage on the OCT, but when you do a subthreshold micropulse laser, there is no damage even on the OCT, and there are three wavelengths: 532, 577, 810. So what is recommended is 577, and we have experience with 577 nanometers laser. The micropulse laser works by inducing the heat shock protein, and this acts by anti-angiogenic and tissue restorative action. There were various types of applications used, and what has been prescribed is a low intensity, high density. That means there is no interburn space, and they are tightly packed laser which are contiguous laser. Recently, with the help of we established International Society for the Subthreshold Micropulse Laser, and what has been decided is that every burn will have a test spot titration, and after having done a test spot titration nasal to the disc, we can use a 50% threshold power. So here are some examples of cases. This is a dentist who is having a chronic CSR for last 5 years, now almost 7 years, and he was on eplenaron, which was started elsewhere. He's also a chronic smoker. This is his right eye, this is the left eye, and when we examined him in the right eye, we found that in addition to a CSR-like lesion, he possibly had a CNBM, a hyperreflective area on the PED, a notched PED. So in the right eye, we treated him with Eylea, while the left eye, when he had this multiple small PEDs and CSR, he was treated with micropulse laser. Initially, after treating him with the micropulse laser, on the first day, his NSD increased, the vision just dropped a little bit, though he didn't notice it, but over a period of time, his visual acuity has benefited. I have treated him now over the last 4.5 years 3 times, and he is done well. So basically, the take home from this is that please rule out a secondary CNBM before treating with micropulse laser. We have treated in his right eye twice and left eye 3 times. Over the period of 4 years, he responded every time. So that means micropulse laser need not be a one-time treatment, it can be repeated. This was an ophthalmology resident who had CSR with a metamorphopsia, so he needed good vision to operate. He had pachychoroid, he had neurosensory detachment, typical confirmed case of CSR. He has been now treated 2 or 3 times, and the last I saw him was in February 2019, where after that he has been doing well, no metamorphopsia, and he had some extrafoveal thickening, but his visual acuity is good and his metamorphopsia has predominantly subsided. So micropulse laser is a tissue sparing laser, and can be given even in a transfoveal manner, and it can be repeated. Coming to vascular occlusions, so this was Army General who had come to us, was a 76 years old male. He presented in March 2015, that is when I started using micropulse laser. And he had read up a lot about non-ischemic CRVO, so he said, I don't want an anti-VEGF. We told him, and he went on to use, control his BP, do yoga, came back 4 months later. The macular edema was still persisting. The visual acuity had not improved much. There was some qualitative change, but he had not improved much, and then he agreed for the micropulse laser. So we treated him. This was one of my initial few cases when I had started using test burn. We gave a 35% reduction of the test burn with a 5% duty cycle in the macular area, and 10% duty cycle beyond the arcades up to the equator in all 4 quadrants. So this is the progress over a period of 6 weeks. He improved from 660 to 624 and 618. This is the reduction of thickness over the period of time and improvement in visual acuity over the period of 6 weeks. So again, showing that micropulse does work in these cases. This was a young girl who had come to me with possibly an inflammatory BRVO, and she was a female non-hypertensive diabetic with a sudden blurring of vision. Normal blood work, serum homocysteine was 7.1 with no past history of attacks. We treated her with Avastin. She responded. Then we gave again after 2 months an injection. Avastin was given. She responded well, and at that time we decided that I wished to treat her because she had to be given repeated injection, which she did not wish. So we decided that we'll plot out, and I didn't have a wide field system at that time, so I plotted out the area of capillary non-perfusion. This is the upper temporal quadrant, the lower temporal quadrant. And we decided to do a 10% duty cycle sectoral micropulse laser. So what I did was I demarcated the entire CNP areas with a continuous wave laser, and I filled in the gap with a subthreshold micropulse laser. You can see here the gap is filled up, and if you can see carefully, this is a follow-up picture which shows that later on I felt that there was an angiogenesis occurring in the capillary non-perfusion area. You can see here there's some angiogenesis, and she is doing well. The visual acuity improved from 624 to 66, and over the period of time the NVD has also become fibrosed, and now she has been on my follow for last 6.5 years. She actually recently, she's moved outside India. She just came back in January. So this is a picture in 2018 with the OCT angio. This is the OCT angio of the right eye, OCT angio of the left eye, and this is the picture of the macula over a period of time. She has developed some retinal thinning in this area, and that's why she is having a metamorphopsia in the 6/6 parts vision. So this is a picture in January 2023, just a few days back. She had come. So this is the area of capillary non-perfusion, and if I look at this area more carefully, I can see that there is some amount of angiogenesis occurring in the capillary non-perfusion area. This has not been reported. I am not sure if it occurs, but we have a documentation in this single case, and I would like your opinion about it, whether angiogenesis can occur in capillary non-perfusion area. This is another patient of BRVO who did not have COVID. This is post-vaccination. He had got vaccinated and then he developed a branch retinal venous occlusion. This was in 13th May 2020. You can see this is the picture was taken a few days after he first presented to us, and he received the second eccentrics in July 2020. At that time we decided that we'll go ahead with the micropulse laser. So we did a 5% duty cycle with a transfoveal application in the macular area and a 10% duty cycle in the area beyond it. And this is his follow-up subsequently. This is his angiogram, which was done last year in July 2022. We are able to maintain him without giving additional injections, and he has received two times he has received micropulse laser. So subthreshold micropulse laser has allowed us to keep him stable over 2 years without any additional injections. So the take-home message is subthreshold micropulse works in CSCR consistently. In chronic CSI, it needs to be repeated. We need to titrate every case with a test burn and then decide the power to be used. And subthreshold micropulse laser also works in venous occlusion in reducing the number of injections. Thank you.
Thank you, sir. It's really an excellent presentation. Just I wanted to know how do you select the area to be treated in case of DRV and CRV? Only on the basis of ischemia or other factors also you consider?
So, whatever I've done till now is done it on the basis of ischemia, on basis of doing an angiogram. So if you do the OCT in the macular area, do the OCT as much as we can. So we can do OCT up to 14 millimeters. Beyond that, the OCT cannot. That's the maximum I can do on my machine. So we do the OCT and we do the angiogram, a wide field angio. Based on the wide field angio, we then go ahead and do the micropulse laser. Initially when the macular edema is there, we do not treat with micropulse laser. The thickness has to come down to about 400 microns. Once it's about 450 microns. If it's more than that, we definitely give an injection before we treat with micropulse laser.
In BRVO, CRVO, you do it for CSD areas only or macular edema?
Macular edema, initially we bring it down to 450 level. Let's say it is about 700 microns. No, but routine laser, you lose the field of vision, sir.
No, I don't think so. In sector laser, if you do, I have not seen patient complaining of field loss.
So now I've taken, if you do a field charting for these patients and see, and you do a sectoral laser, the number of injections reduced, the macular edema doesn't come back, so that's the advantage.
But I think all of us have a wonderful experience of minimizing macular edema on a long-term basis. After you give anti-VEGF, one or two injections, and then in between what I do is when the peak action is there, we do sector laser or scatter laser depending on this thing. And micropulse may have a role, but repetition may be there.
So there was a paper which showed that targeted laser, peripheral laser for a CRVO actually doesn't work. No, not with micropulse, no continuous wave laser. So we used to do a lot of peripheral laser. All of us thought that we are trying to reduce the area, but
my question is micropulse versus routine 532 laser in BRVO or CRVO. So any opinion anybody else has?
So we'll go for a conventional laser. Actually,
Because we don't have experience
Ajay
actually.
is talking recannulation. I would suggest you, if you have cases of macular ischemia, then you give some threshold laser and see what is the recannulation. Because that will be more helpful in terms of vision and you will have a better documentation of that. If that can be proved, you can have a recannulation with SMD, then
So I have only one case where we have documented this. In the macular ischemia cases, I don't have any proof that such a thing happens. Yeah, maybe over a period of time, I don't know.
Experience of micropulse 577. So that is the reason we are not able to comment with a lot of
I just had a question. I've been hearing for so many years your results on micropulse. Why has not the technology taken off the way it should have been?
So what has happened is that micropulse laser is not a multinational driven technology. Any technology, if you look, takes over. If eccentrics comes up, there is somebody pushing it. Nobody is pushing micropulse laser. So recently we formed the international. So there was a lot of confusion where how much power to use. You see nothing, you do nothing. That's what was the thing. So people said, कोई laser burn आया नहीं है तो क्या होगा इसमें? But now.
Similar to what we used to do before PDT, TGT laser, that you have a test one nasal quadrant, then reduce the power to 50%. Yeah. Here the technology is different, but I agree with you. If it was so good, it would have made a revolution.
There is
Just one point I would like to add here is we use micropulse, but in CSCR,
577.
577, yellow laser micropulse MPLP. In CSCR, definitely we have seen wonderful results. Because we don't have any other choice. If there is a foveal leak, we don't have any other choice because of the non-availability of the vertiporprin or various other reasons. But in diabetic macular edema, it will be very bad to use it.
No, diabetic macular edema, I agree. But diabetic macular edema, then we have to have a long-term thing. If I can say that I have reduced the number of injections for the patient, that itself, I cannot undo the diabetes.
This has to be less than 250 or 300 is what the
450, yeah.
Beyond that, and it really doesn't work.
Cinemas, the kind of macular edema, people propagate for micropulse drugs normally don't treat also. Because diabetic macular edema is a multifactorial etiology. It's not, you control diabetes, hemoglobin, all these things tend to improve with them.
Srinivas, in diabetic.
CSR,
Yeah.
therefore I didn't touch it. My point was of the diabetic retinopathy as well as in vascular block.
And secondly, Vishal, it's an anti-VEGF driven.
Actually, there is scope of competition
Majority
of
of
retinal
the
function
You were saying something.
with
yes.
the conventional
I
laser.
have experience of few
Micropulse
cases when I was with Dr.
Yeah.
Retina. So we had used micropulse laser. So
I think there is
it
no
worked
instance.
very well in chronic CSR cases.
Yeah.
We tried it in few patients of non-responding DME. Those 350, 400 microns, it doesn't go. So, but we didn't have very good experience, at least in DME. But in CSR, chronic CSR cases,
Yeah,
it
it's
worked
giving a
well.
promising result.
No, Jay, that's what Srinivas said. In CSCR, we didn't question this. I think that in the absence of vertiporprin, if vertiporprin was there, I still prefer that. Because there the results, whatever we have done, is nearly 100%. Whereas micropulse, the question repetition.
So any experience with acute CSR subfoveal leak micropulse?
So acute CSR, we allow them to subside on their own, which is about 6 weeks.
If there's a subfoveal leak, because PDT is not available now, so have you tried it in those cases?
I have done transfoveal.
So what is your case?
Yeah,
What
yeah.
is your take?
No, that is one indication where because PDT is not available.
Acute CSR, actually what he said, Ajay, is absolutely correct. Only place where I have treated is one doctor, I surgeon and a pilot, that's it. Because they require some microscopic or a very sharp. And they want it very early. You see, there's no time for them to wait for 6 to 8 weeks or for spontaneous. Yes.
I have a patient with bilateral case of pit with serious detachment, and I had a yellow laser done by Jacobi, and it worked in that case. So even in pits, you can try.
They did that walking up around 2-3 rows.
Yes.
But the pit pathology is totally something else.
So there you did micropulse or?
And young patient, I didn't want to do a vitrectomy.
Abhishek, there was a time way back, when vitreous surgery was not so well developed. We used to do as a routine 2-3 rows, temporal margin of error. The result was not miraculous, but believe me, the result was to the tune of around 25 to 28%. That it will.
Sir, but that anesthesia was for creating a chorioretinal scarring bridge. But in micropulse, we are not causing any such chorioretinal scarring bridge. That is well.
So that will be one odd case. I'm telling you, Sharaf, that may not be treatment. Observation. That's an observation which everyone should keep in mind. Don't advocate that. Please.
No, in with do have fluctuating course in their initial days.
Natural
So,
course.
but
And then initial natural course, they might come down and then they might again have
no, this
until
patient
they
I've
become
been seeing
chronic.
for more than 6 months now.
So let's see. Time we have to finish 2 more talks. We took the liberty of more discussion because
Slide change, sir. Jay will be presenting first and then I will.
Oh,
Dr. Jay will be presenting on PCV via cycle.
before Jay starts, I think this article, on PCB, everybody should have, because I have read this article 2-3 times, and every time I want to read again, and I have heard also. Wonderful job done, Jay, for PCB.
Thank you, sir. So, I think I had presented this talk a couple of days back, so I think few of the audience were not there. So we just go through these updated guidelines once again. So as we know, if we see around say 10 patients on NAMD and if we do a multimodal imaging, maybe more than 6 or 7 may turn out to be PCB, because they're very common in our Asian population. So the previous guidelines that were proposed and published were way back in 2018 with a literature update only up to 2015. So since then, a lot of changes have taken place in the management of PCV, and over the past 3 years, PPT is also unavailable in India. So that is why the VRSA convened the Indian PCV panel to conduct a systematic literature review and formulate the updated guidelines for the management. So there were a few changes in the nomenclature that have taken place now. So like the polyp has been relabeled as polyp or lesion, and the branching vascular network has been relabeled as a branching neovascular network. So these changes have been done to better represent the neovascular character of the network that is there. Then coming to the imaging in these patients, so till recently, ICG is still considered to be the gold standard, and that was mentioned in the previous set of guidelines also. But now, if you look, primary management has changed to antivirus monotherapy, so we may actually not need to do ICG for all these patients unless we are actually conducting a clinical trial where we want to see a particular endpoint like polyp regression or anything. ICG may be done only for patients who are not responding to multiple antibiotic injections where we need to do a thermal laser to suppose an extrafocal polyp. So those are the conditions where we can consider doing an ICG. Next, coming to FFA, it is not mandatory in all these patients because our line of management does not alter with that unless we are suspecting a patient having an underlying CSR where the source of the fluid, subretinal fluid, is actually a leakage rather than the neovascular network itself. So the primary imaging modality currently is the OCT, and there are multiple OCT biomarkers that help us to differentiate it from neovascular AMD. So these two are the most important, that is the thumb-like polyp or the tall peak PED and notching at the end of the PED. So they represent the polypoidal lesion that is there in the sub-RP level. The other OCT biomarkers include presence of a hyporeflective ring surrounded by a ring of hyperreflectivity that is attached to the undersurface. So that also represents a polypoidal lesion, and the presence of the double layer sign or the flat irregular PED that represents the branching neovascular network. Now, in the new guidelines, few additional biomarkers have been added and few have been better defined. Like a sharp peak PED has been defined as having a vertical inclination of more than 70 degrees and a height to weight ratio of more than 1. And the tomographic notch has been relabeled as a complex or multilobar PED. The other OCT biomarkers include presence of a thickened choroid of more than 300 microns, or it can be matched according to the age or the reflective error of the patient, or presence of a focal dilated hairless vessel. But very important point is it has to be present in association with a thinning of the choriocapillaris layer over time. Now, on first, OCT imaging is another modality that is coming up fast now, and on that, presence of this complex RP elevation that we can see the two dark rounded areas, and that is attached. There is a VNN. We can see the hyperreflectivity, that is a branching neovascular network that connects those multiple PEDs, and the presence of fluid that is chiefly subretinal and not intraretinal. So to differentiate them, there are certain major and minor criteria have been proposed. So the major criteria include the sub-RP ring-like lesion on fast complex RP elevation and presence of the sharp peak PED. And the minor criteria include presence of the DLS, a thickened choroid, and a complex of multilobar PED. So coming, the OCT angio may provide complementary information, especially to detect branching neovascular networks where it is more sensitive than an ICG, but it may not be necessary to PDT with 3 loading doses, but now it has been completely changed and antibiotic monotherapy has become the definitive choice for management of these eyes. Now, this is not because only the PDT is unavailable, but because PDT has its own sets of drawbacks, including increased chances of complications like hemorrhages, rips, and choroidal ischemia and atrophy that worsen with each repeated treatment. Then coming to the choice of antibiotic injections based on the previous guidance, ranibizumab was a recommended agent of choice based on level 1 evidence in 2018, but subsequently many new trials, especially the PLANET study, results of the long-term PLANET study has come and that is recommended aflibercept should be the preferred anti-VEGF agent of choice because it is far superior to ranibizumab based on its action against VEGF, PGF, and also because of it provides longer half-life. So we can give the patient even 8, 12, or even 16 weekly regimens. Let us quickly skip to the slide. So basically the Everest study proposes ranibizumab in combination with PDT for best outcomes, whereas if you look at the PLANET study, it says that monotherapy is on par with rescue PDT with anti-aflibercept. The newer agent, brolucizumab, has also shown very good promising results, especially in resolving the PEDs and all. But few of the trials that have taken place have shown a very high level of intraocular inflammation, ranging from 15 to 19%. The subpart of the Hawk study had a IOI rate of 15.4%. And also there are any studies lacking that compensate to PED. So maybe we can reserve brolucizumab only for patients who are very resistant to even aflibercept treatment. So the follow-up of these patients should primarily be based on OCT, and ICT may not be needed or it can be done only in patients who are not responding. And the treat and extend regimen with aflibercept works best for these patients. This is because data has shown that treat and extend is associated with reduced risk of recurrences and subfoveal fibrosis as well as improved visual acuity outcomes. And we can even increase the dosing regimen up to 12 or 16 weeks. There are multiple studies that have shown that 80% works well for refractive PCVs who are resistant to either Avastin or ranibizumab or even photodynamic therapy. So just to summarize, the guidance emphasizes that PCV is a multifaceted disorder and a timely imaging with OCT is very critical. It is best to start the patient on antibiotic monotherapy, especially with longer acting agent like aflibercept. And the current recommendations would provide a broader framework for the retinal physician for the diagnosis and management of PCV to achieve optimal outcomes. So they are available for free download in the August issue of the IGO. Thank you very much.
Only one question is there because is that treatment extend in PCD is similar to treatment extend in ARMD or is something?
No, it is very similar to ARMD.
And what proportion of patients ultimately, because PCVs are notorious, although people claim that you see with aflibercept the polyps disappear. I don't think so that disappears, they become inactive.
Yeah, they will inactive. So I think one of the studies that I had shown, that has shown that by the end of 1 year, almost 60% of the patients were on every 30 weekly injections, and around 7% patients could achieve 11 weekly. So on an average, I think 2/3 of the patients can be continued on at least a 12 weekly regimen at the end of the year.
You use a loading dose for these. You use a loading dose also.
Yes, loading dose.
And after that treat the next.
Yes, loading and then treatment.
So that's why Vishal I asked, is it similar loading to
Very
extend or is it something different? Because I personally think PCV required more number of injections than more aggressive approach than
Then
Yes. Question for you. You said after this slide, ICG is not necessary, Opta is not necessary. Is that take-home message that for a general ophthalmologist that OCT is enough?
yes, so because these are based on the evidence and also for a real world management of patients, especially in an Indian scenario. Now, as you know, OCT is a very important imaging modality, but the detection rate of polypoidal lesion per se is quite low. So it is good for detection of the VNS in that region. But our primary treatment is based on the OCT biomarkers and not the OCT angio biomarker. So even if we see a network on an OCT angio and if there is no fluid, we usually observe these patients, although we may call them to follow more frequently than a patient who doesn't have a network. Coming to the ICG, ideally if we have the imaging modality, we can consider doing an ICGC where those lesions are located. If they are extrafoveal, we can consider doing a thermal laser also. But it does not actually alter our line of management. Previously, ICG was necessary to measure the GAVs to see, how much do we need to treat. But our primary treatment now has been switched to anti-VEGF monotherapy. So,
but Jay, whatever you see a propagating considering real world scenario,
yes,
and everybody does not have ICGA. But people who have ICGA, I don't
yes,
think they do not do ICGA and depend only on this.
Yeah.
Because it provides valuable information with regard to laserability. If you laser, you have to still find out the cause. Then
yes. So if we have it, it is always best to do it.
Jay, can we stop because next people already come. Let's see.
And we have more audience also, sir, from the next week.
5 minutes.
Yeah, thank you very much, AIO's team, the Lalit sir, respected chairpersons. So this was a slight repeat of the talk from yesterday, so I just changed it a little bit to make it a little more interesting. So this was one of the case of the very bad PDR when we the first started to do under the 3D visualization system. So basically I was little skeptical because this was the third day when I first started doing this way back in 2017. So I was little skeptical, thinking that it has a learning curve and it has the lag and everything, but fortunately I couldn't see much of difference, and you can see here I'm just going ahead with the bimanual surgery. And for the people who say that the peripheral visualization is really compromised in these kind of cases, I did not see any compromisation of the peripheral visualization. Here you can see it by yourself. There is no compromisation of the peripheral visualization. The only thing is you need to adjust the settings of the microscope, moving the joystick, so that you get a good visualization even in the periphery also. In fact, peripheral visualization is much better if we do it in a proper way and do it with the indentation. So I'm just trying to show this. This was almost a PL positive in both the eyes. I tried to remove most of these membranes, and finally I could somehow get a 20/80 in this case. And this is the newer visualization techniques. What we are using is now using you can see that it's a very red, bloody red kind of this thing. And so here I'm using the red free filter. So using the red free filter, it definitely helps to fluoresce these membranes. You can see that it looks like I cannot say it like a fluorescent membranes, but definitely the visualization definitely improves. The fluorescence definitely improves. So that is the advantage of using the red free filters. There are many other filters you can play with, the gamma, the saturation, the hue, or most of these things. So only advantages, the better we see, better we do, so that we have less iatrogenic breaks in these kind of cases. So this is the next case. I thought I would bring it to the interest of the students or the fellows. I just wanted to show how the multifunctional cutter works here, and this whole surgery was completed with the help of the cutter itself. So this is the segmentation what we are trying to do thanks to these 25 gauge, 27 gauge, 10K cutters and the curved end of that, so that we have it acts like a forceps also. So here you are see I'm trying to do segmentation and delamination with the help of the cutter itself. I have not used a single bit of forceps in this complete surgery. I am not trying to say that it's so advantageous. At times we might need the forceps, but definitely with the advent of these new gauge cutters, definitely the usage of the forceps can also come down. So here you can see I am just trying to do a delamination. I cut it into different segment pieces and then completed the surgery, and I just did a ILM peel at the end, and this was the post-op. The patient had pretty good vision in this case. Now this is the another case where, oh, I'm sorry for this bad quality of the video. Okay, so these are the few of the bad cases. I'll just, this was the case admitted in the blind school, and when we went for annual checkup, so this was a pretty, I think 14 or 15-year-old boy, where we tried to see if we can do something good for this. So I did a lensectomy in this case, and now you can see the retina was seen under the lens. So here what I would suggest is better to do it under the microscope first. Try to peel as much as membranes under the microscope as much as possible, and then try to give some space for the infusion to enter. Here you can see I'm just trying to remove as much as membranes as possible, and then try to turn on the infusion. So turning on the infusion, now you can see inside it's a completely retina. The retina was thrown into multiple folds. So meticulous peeling of these membranes, definitely patience and perseverance is the key in any of these cases of PVR. So here all the peripheral membranes were also removed, and fortunately I didn't have to do any retinectomy in this case, and the laser was done. And this was another interesting case. I wanted to show it to you all. This was the case of subfoveal PFO. 2 slides. You can see here I removed the PFO, and the only mistake I did here was to do an ILM peeling in this case. So I thought it had thrown into different folds, so I did the ILM peel, and the next week post-op the patient developed MAC hole, and now you can see it was a MAC hole RD as well. So here I did a ILM. I tried to bring it to the center, and it's almost like an ILM transplant. Under the PFO I just slided these ILM flaps, tried to bring it to the center, and while doing a fluid air exchange, unfortunately the flaps came into the forceps. I tried to just slide it, it came into the forceps. Once the flap is lost, it's lost. And not just that, I even had a choroidal detachment, temporal CDs as well. So here I had to drain the CDs, and the heartbeat was high because she was the wife of a lawyer. So the only choice left to me was to do a neurosensory graft. So here I used the 42 gauge needle. I tried to, either you can do it bimanually or unimanually, whichever. I'm just trying to show this unimanual technique. Just under the PFO, slide it in the macula. I just confirmed it with AIOCT to look at the orientation of the graft on the MAC hole, and fortunately the patient had around 20/80 vision in this case. So I think I'll, in the interest of the time, I'll just try to complete.
Shiva's wonderful videos.
Thank you very much.
But ILM flaps are never to be held with the
Forceps.
because they have to be glided under PFC.
No, I did that, sir, but the only thing is, after putting a PFO and fluid air exchange, it moved. So once it moves, then I thought I could just slide it, but it just burnt hands in this case, but fortunately it turned out well.
But under PFCL, if you glide it with the help of a diamond duster or some automatic instrument, then only it is successful. Otherwise, if you hold it forceps, it is gone. It is gone. But the second last surgery was very daring, where directly under microscope you're doing something like AIOCMTC1 surgery, and that patient, what was the indication? Was it one-eyed patient or?
Yeah, he was bilateral bad RD, and he was in the blind school. So when we did an annual checkup of the blind school, we thought let's take it as a challenge and see. And fortunately, he has some ambulatory vision, and now he is out of the blind school.
Thanks.
Yeah. Thank you very much.
And thanks all the speakers of this session, and thanks the.
Thank you, sir.